Hello and welcome everyone for tonight's Just Ask from the EAO. This is your monthly appointment with one of the superstars of dentistry, and the only thing you need to do is to ask questions. I'm just here to moderate and I'm just here to hand over your question. And it's getting to the end of the year. It's our second last Just Ask, and we have a very, very special guest tonight. It is Dr. Stefan Bienz from Switzerland. And Stefan, he has not only one prestigious appointment, no, he has two prestigious appointments. He works as a part-time faculty of the prestigious University of Zurich of the Clinic of Reconstructive Dentistry, and he took over the prestigious office of Uli Grunder, and he pretty much shares the best of two worlds together. Stefan, with this, I don't know what else we should say about you. Welcome to tonight's EAO Just Ask. It's a pleasure to have you.
Hello, dear friends and colleagues, and thank you, Stefan, for the nice introduction. It's a pleasure to be here tonight.
Yeah, we have a great topic. We have a topic of soft tissue augmentation. This time it's again a little bit of more surgical topic. I already see the blood dripping around your first slide. So a lot of people probably will be happy. Last time we had a pros topic. There are already a lot of people logging in from all around the world, Stefan, from Paris, from Tunisia, from Saudi Arabia, from Spain, from Libya. So pretty much all the people, they want to hear your content. And Stefan, a case came across my office. And you are the master. I mean, you get the input from both sides. So I want to get your input, what I did wrong, or where you maybe say, well, okay, Stefan, that was okay. So I took out a canine, I placed an immediate implant, I took a replacement material, a dermal matrix, I placed it into a tunnel on the buccal side, and obviously I also grafted it with a bone graft. What do you say? Is that soft tissue management as we would do it today, or is that something which we did some earlier times?
Stefan, that looks very good to me. So first of all, I can see that you carefully extracted the tooth. I think this is one of the most important things when you go for such a procedure. Second, I see that the implant is in the right position. Well, I cannot judge it vertically, but otherwise it looks absolutely perfect. And then whenever you go for such a procedure, and especially in the canine region, you have to expect a lot of shrinkage. I think it's very good that you did something against it. Now, using a substitute for this indication, I would say it's a modern way of treatment with low morbidity. But you are here really at the front. So this is a modern treatment concept, and we do not have too much data for this.
Okay, I get your point. So everything else was fine, but the thing with the dermal matrix, But that's why we have you here. Your first slide is connective tissue graft. So I guess your choice would be something different, Stefan. There are a lot of people now logging in from Italy, from Austria. Michael Payer is here. Hi, Michael. Eva is here. Hello, all around the world. Stefan, we want to hear your content. I cannot wait to hear your content. Please, as you know, it is a little bit the tradition of this Just Ask is I just go in between your slides. I ask you a question. If someone of the auditorium has a question, just push it over to me. I'll give it over to Stefan. We're two Stefans. I think we're friendly to each other, and we will make it a great evening. Please, Stefan, go ahead.
Fantastic. So I will start with the question, what is the reason to perform soft tissue augmentations? And I think Stefan's case was perfect as an introduction. I think mainly it's an aesthetic indication. We have some data that there is also a biologic rationale to do this, but still the data there is limited. I see certain indications to basically regenerate everything. You know, it's a little bit easier for the patient to clean, but there we are already a little bit beyond the literature. So mainly it's an aesthetic indication. And why are we doing it? Because we want to have such results. And in the meanwhile, treatment success is also based on aesthetic outcomes. So it's maybe different compared to 30 years ago, where everybody was happy when he had a white tooth again, which was fixed in the mouth. So the expectations are nowadays much, much higher. So what does it need to achieve such a result? You can use soft tissue augmentations in terms of implant dentistry at several time points. I would just like to let you know, for me, the 2 time points where I do it most often is in conjunction with immediate implant placement, what we saw from Stefan. But today I would like to focus on the moment where the implant is placed, the GBR is done, but the abutment connection is not yet done. It's maybe also because I'm coming from a school that teaches this way since many, many years. And this is the case. So it's a young patient, medium to high lip line. You see something is not right about tooth number 12 and 11. She's healthy. She had a trauma in childhood. Those 2 teeth have been treated over the years. You see here the periodontal chart. There's some increased values. And when you see the X-ray, you see why. There's a horizontal fracture on the central one. There's a resorption from the mesial side on the lateral one. Both have periapical lesions. The endodontist said there's no more option to treat them. And so we decided to extract those 2 teeth. And the plan was to place an implant at the central incisor and to later place a crown with a cantilever. Now, we skip some parts of the treatment. This is the situation after teeth have been extracted. The implant was placed in conjunction with GBR, and now here we are. Doesn't look too bad at first sight, but when you draw the line, the reference line is the papilla between the 2 teeth on the contralateral side. And you see we actually miss a lot of volume already. So it actually looks better at first sight because of the palatal level, but no patient will ever say, "Thank you, doctor, for regenerating my palatal papilla. You need a buccal papilla." So this is what makes it difficult. And the only way to achieve this is if you do a soft tissue augmentation on top. So we combined this with the removal of the membrane from the GBR. Nowadays, I like to harvest the graft with an open approach. So I de-epithelialize the palate, then I try to remove lamina propria. Mainly, I leave the submucosa where it is. It was checked whether the flap can be closed, and this is the wound closure. All my patients, they leave the office with some sort of coverage at the palate, so this patient had a removable partial denture. This was the wound healing, and now we jump to the final result. There have been many prosthetic steps in between. This was the final result. It's not 100%, but it was a challenging situation. You have a perfect contralateral side, and this is the smile.
Stefan, I already have a question for you. You took a de-epithelialized connective tissue graft, right?
Yes.
You said you have changed that. Why? I mean, do you think it's less volume shrinkage? But maybe some people say there's a tendency for this tissue to proliferate over time. Is that also something you see and what you're maybe afraid of?
Yes. There's the 2 sides, exactly. So first of all, when you do single incision techniques, this is where I was coming from, you tend to leave a lot of the, let's say, the good tissue. So in the deeper area of the palate, you find loose connective tissue, and in between is fatty tissue and glandular tissue. The dense connective tissue, you find it right below the epithelium in the lamina propria. And we know that if you want to completely remove the epithelium, including the retapex, then you have to remove about 0.8 millimeters. And there's different concepts for this. So I like to use a mucotome. Mm-hmm. If I'm not able to access it, I use a diamond burr. I don't like to de-epithelialize outside the mouth.
And what about proliferation over time? I want to nail you down. Does that happen? And do we see that?
Yes, it happens. It also happens to me. And I think the main thing you have to see there is that you have a modality to remove the epithelium and to be sure during the clinic. This is actually why I like to do it with the mucotome.
Do you think it's a matter of residual epithelium which you leave?
Yes, I do think so.
Okay.
It's also sometimes maybe you see proliferation first, but if you would leave it and wait long enough, one day you will find an island of epithelium growing through the local tissue.
Okay, perfect. Got it.
So we started with this case, and now I would like to shift a little bit the perspective of the patient. Now, this patient went through a very long treatment. You see, 14 months, 18 appointments, 4 surgical interventions. This includes tooth extraction, then implant placement with GBR, then the one we saw with the membrane removal, and finally also the abutment connection. Now, if you want to achieve a good result, everything has to go according to the plan. This is the first challenge, but also for the patient, and this was also her feedback. Actually, everything was okay. She also asked for the best result possible, but the worst over the entire period was the donor side of harvesting a connective tissue graft. And this is basically me when I see an indication for a connective tissue graft. Looking forward to it, as we all do, we like to do it. I don't like to talk about patient selection because you don't select patients. You have a patient coming to your office with a problem, and then you can talk about different indications or treatment modalities, but you cannot send him home and say, give me the next one. So it's about the indication. Now, if you start explaining them, the reaction is quite different. So you say, yeah, we take a piece of connective tissue from the palate, it's going to be fantastic. Patients are rather hesitating. And you all know, even though if you haven't had such a procedure, pain at the palate is something with big discomfort. It's much more compared to the recipient side where you just have the swelling in. The pain is much stronger. And I would like to focus a little bit on this. So first of all, I want to make you a little bit more sensitive when to do this. And we all underlie a certain cognitive bias. So the first one is actually that we are here tonight. So we are all interested in the topic. So we are basically already in a bubble. And for what we want to see when we go to congresses with the nice pictures and everything, and actually today I did exactly the same. I showed you a nice case to start with the topic. So be a little bit more careful when you have the patient on the chair and try to understand him and whether this is really needed, whether this is really helping him at the end. And this brings us to the second point, it's patient information. So the way you inform your patient has a very, very big influence how he's going to decide. Our generation learned the concept of shared decision making, meaning that you want to inform your patient as good as possible so that he can take the decision or at least be part of the decision. But the way you explain it to him will have a big influence how you decide at the very end. And for this, I want to show you a little bit of data. So this is a small prospective case series from good friends of mine, and the treatment modality was exactly the same as you have seen in the case that we were looking at. And the nice thing about it is the transparent reporting of each case, and they did scans, and you can see exactly what happened with the overall volume over all those different treatment steps. And of course, we will focus on the soft tissue augmentation. Now, the first thing that you can learn from here is when you look at the mean gain after bone augmentation, we are at 0.7 millimeters. And when we look at the soft tissue augmentation, we are at 0.55 millimeters. So the contribution of soft tissues to the overall volume is huge. Huh? It's maybe 40% according to the data here. Now, what should make you a little bit more cautious is whenever an effect is as large as the standard deviation. So this means that here we have a large variability, and you can see even in the hands of maybe the greatest surgeon I ever been watching of Uli, there's 4 out of 15 cases without a volume gain. So this is what I meant before. You should be careful when you consider to do it or maybe not to do it. And when you look at the literature, this fits quite well into the bigger picture. So please don't nail me on these percentages. It's just a rough estimation of what I'm usually reading. So we have quite many dehiscences, not primary wound healing. Then we have quite a bunch of cases where we don't have a volume gain. And finally, if we talk about vertical volume gain, it's not reported that often, but when you look at the studies that have it, so it's basically throwing the dice. You cannot plan for this. And this is the summary of it. So soft tissue contribution, definitely yes, but the predictability and the complication rate, this is an issue. Now, the most important question, if you do it, does the patient see the difference? And we were addressing this recently, and Sophia Sadilina and Franz Strauss put a lot of effort into this review. And our question was, we tried to compare the measurements of a clinician with the ones coming from the patient. So on the left side, you see representative a pink aesthetic score taken by the clinician. And on the other side, we have a questionnaire where the patient reports his aesthetic satisfaction. And we try to associate those two. And the difficulty here is you cannot, as usually for a systematic review, compare the means of studies. It's not working because then you would compare one center against the other or a treatment modality against the other. We needed to know the difference between each single measurement. So we asked all the authors for the raw data. And here's an example of what we calculate. You see 2 patients here, and one is 100% happy, the other one is 80% happy. And on the right side, you see the pink aesthetic score. First one, again, 14 points, 100%. The other one, only 6%. And exactly this difference is what we wanted to know. And below, now you can see the results. So for this particular analysis, we had data from 171 patients. Pink aesthetic score and satisfaction, no significant correlation. And this actually happened to us with all the outcomes we were comparing. It's maybe the most frustrating piece of research that I have ever published, because we said, yeah, we are here tonight for a reason. And of course, I do believe in it.
Stefan, I have a question.
Yes.
Because for me as a clinician, it would be good to sort out the risk patient. I mean, I see the same in my daily clinical office. I mean, I sometimes take a picture to show the patient how good this is. And the patient say, yeah, the tooth is nice. And you know how it is. Did you see, are there risk patients where I really should think of soft tissue augmentation? We always just quickly say high lip line. Is that the case? Or what did you see in your research?
Well, high lip line, thin tissues, I mean, this makes your surgery definitely more technique sensitive, and the outcome is maybe more important then because the patient shows it.
But is that so? Did you look at it? I mean, really are patients with a high lip line, do they not really care about the result too much?
Well, you are right. Maybe there's no data for this, but I would suggest that it is like this.
Yeah.
And maybe if you compare your young patients in the office compared to the ones which are 85, where you might do an immediate implant placement, And if the papilla is not 100%, they might care less.
Okay, I got it. So we still have to stick a little bit to our old risk regime, high lip line, young patient, aesthetically challenging patient or whatever.
Yes, but these are not contraindications. It's just risks and benefits.
I get you.
So how
you.
much does my patient want to have a perfect result?
Get you.
And for example, my first patient that I showed tonight, she said from the beginning, it's okay for me. I will go through it. And I mean, she did very well. I was lucky. She had perfect wound healing each time I did anything on those two sides. And like this, we achieved a good result.
Okay, great.
But it's, when you talk about other risk factors like smoking, for example, where we know that this impairs wound healing, then of course you have to be more careful. And this also goes into your risk and benefit analysis, but it makes a certain shift then.
Sure.
So here's a small explanation of maybe why we didn't see a difference in this systematic review. And we have a so-called ceiling effect. So you can see that all the data for satisfaction is basically on the top of this graph. It's between 8 and 10. So actually, the patients were not that sensitive in deferring compared to the pink aesthetic score, where we were actually able to work with scores between 6 and 12, where we see that it seems like the score has a certain value to differ between good and bad results. This could be one explanation. Yes, and this is our patient back with some Photoshop. And question is, would she have been happy if I sent her home like this? I think probably not. But I think if we talk about the awareness for us, when we talk about an intervention which is surgical, which has a relatively high morbidity compared to everything that dentists basically do, I think it's very important to discuss this topic.
Right.
So every time before I offer the patient and let him know the treatment plan, what I want to do, I have a little picture in the back of my mind. It looks like this. So first of all, I always think again, does the patient really want it? And do we have an advantage on the long term? The patient might not be able to decide so much in terms of the biology. You might tell him, look, it's very important. But when it's about aesthetics, I think the wish of the patient is very, very important to consider. Good. The donor side, Stefan, you asked me already. Here's another short video, how I de-epithelialize using this mucotome. And with this, I think I have the best control that I can fully de-epithelialize. Here, I'm removing the epithelium, and afterwards, I harvest the connective tissue. It's sometimes not so easy in terms of the access. Then I have to switch to the burr. But just for me personally, actually, I have the best control like this. Because in all the areas where the mucotome went over, I actually know the epithelium is gone.
Stefan, there's actually a question which fits perfectly to the video from Mario Romandini. Hi, Mario. Great that you logged in. And actually a great question, what I would have expected from him. He says, how can you be really sure that the epithelium is gone? He says, well, some of the Retipacks, they maybe go deeper than 0.7 or 0.8. And if you really think that like proliferation, all this makes a difference, how are you really sure?
Well, you are right. Clinically, I mean, you cannot be 100% sure. Otherwise, we would have to do histology of our graft. We recently published a work on 80 human biopsies from the palate, so quite many, and we did measurements, and the average thickness of the epithelium, including the red apex, was 0.5. And with 0.8, I think, and also when I look at the minimum and maximum values of the epithelial thickness, I think with 0.8 you should really have everything. I think the problem is not the knowledge behind it. The problem is more technically, because there's always a corner where you might not have reached everything, and most probably from there you're going to have the proliferation later on.
Great. Mario, I'm not sure if that was in your journal, but he definitely has the data on it. Thank you.
No, it wasn't.
Okay, great. So, okay, interesting. So, what is your take? What we do with donor sites?
With donor sites, this is a nice study that recently appeared, 72 patients, and they show 4 treatment modalities, how they cover the palate. And the thermoplastic stent, it's the one you see in the lower left picture, actually performed better than all the others. It's the pink line, and you see in terms of pain, swelling, bleeding, it's always at the bottom. So this is the concept that I'm trying to apply to my patients. Many of them have a removable provisional that covers the area already. I'm not so much the immediate loader of implants. This is why many of my patients have this at the time when I do soft tissue augmentations. And whenever I treat the patient, also for free gingival grafts, for example, I use a material to cover this area. You have this done quite fast. And with this, the patient can wear it. Some wear it for 2 days, some wear it for 7 days. But I'm pretty sure it helps a lot. I also know it personally. I did it once as a pilot study on my palate. And as soon as you have a coverage, you basically have no pain. But as soon as you have the tongue there and the saliva, it starts to burn.
Wow, that's a researcher, did the research on his own palate.
At least trying.
Just one question. Just a very clinical advice. What do you tell the patient? Leave it in for 24 hours and then take it out one time to sort of clean it, or make it very concrete? What do you tell him?
If they have a removable provisional, I tell them actually to, if they don't have a severe bleeding that is coming from underneath, I tell them to leave it on the wound till the next evening.
Yeah.
So then it's the first time they remove it, and then they have to wash their mouth. And this is also the time point where I recommend them to start with the chlorhexidine mouth rinse.
Perfect.
And before, just do nothing.
Yeah, do the same.
Good. We have one more topic, and it's actually, Stefan, it's your topic that you introduced at the beginning. So, is there a replacement so that we don't have to go to the palate anymore? And I'm absolutely sure in the future, one day, we will only do this. Here's some data from Cristina Valles. Basically, the first meta-analysis I know that compares connective tissue with volume-stable collagen matrices, because the volume-stable ones are relatively new. So the first one came to the market a little bit more than 10 years ago. We have to say the matrices that have been used in those 8 studies, not all of them are really volume-stable. But nevertheless, when you look at the data, it actually clearly favors the CTG group. So not really good news in terms of that. Now, why is that? And this was actually the point where I entered research myself a little bit. And this new material was there, and everybody was a little bit disappointed from the first studies. A lot of dehiscences, less volume gain. And the problem is always, you have to compare to the gold standard. This is an important concept. Not that you compare the worst with the second worst. We always have to compare to the gold standard. This is correct in research. However, if you have a new invention, and if it's a little bit more complex, it's very biological here. You cannot expect that you have a connective tissue graft out of the box immediately working exactly the same way as you know it from the connective tissue graft. And then you even expect that if you apply it the same way, it works the same way. So this is a little bit too much. So I think the material should be given a second chance. And I show you a little bit about the differences. So this was what I was mainly working on. What is the main difference between the two? And first of all, we were thinking about a very, actually obvious difference. So when you have connective tissue, this is filled with liquid to a large extent, and the rest is dense connective tissue. Physically spoken, it's almost not compressible. And on the other hand, we have a sponge. It has a memory effect. It jumps back to its shape, but the resistance to compression is very, very weak. And you can see this here in a video of Stefan Bienz. And you can see how this material soaks up the blood underneath the flap after everything is closed. It jumps back into its shape, but I'm pretty sure that underneath the sutures where we actually want to create the volume, it's completely compressed. So it doesn't help us to create the room for regeneration. And this was, from our thoughts some years ago, the biggest difference between the two. And we tried to test this. We created some boxes with a cover, with a slide cover, where we placed the material inside and we placed this in rats to see the healing. These are the boxes. They were inspired by a wine box. And you can see we placed the normal amount of material, the double amount of material, and the fourfold amount of material. Now, this looks like a lot, but when you put saline over this, you can easily compress it and close the box. And I think this is exactly what's happening underneath the flap. And what we found is after 12 weeks in those heavily compressed ones, that there was basically not a single cell in the center, where we had much more ingrowth of cells and connective tissue when the material was not compressed. It's actually an obvious finding because when you create a material, you search for a porosity which is ideal for cell ingrowth. But if we don't apply it in the clinic as it was created, it will not work. And here's a case where I try to show you where I like to use it. So nowadays, I'm not using it in the full range of indications that I have for a connective tissue graft. But there are certain indications where I think it works fantastic. So this is a case where I already have mature tissues and I just need more volume. And it's in the upper jaw. And in the upper jaw, we have the option to do an additional palatal sliding flap or tinty flap. And we gain another 2 millimeters of release from the palatal side. And when you compare the left side picture to the right side picture, then you can see even though there is only a matrix underneath, we were really able to create a lot of new regeneration space. And in these situations, I think the matrix works very well. What we have to say is the matrix is technique sensitive, so you really need to have a very good wound closure. I also prescribe my patients antibiotics when I'm working with it.
So, Stefan, in order to understand that again, do you say that the problem of this matrix is that in the most decisive area, the most coronal spot of your flap, it's compressed too much?
Yes.
And would you allude, I don't know if everyone got that, what do you do against it? Because, I mean, it's more volume, you have to close a flap. What should you do?
So one of the problems that we had when we think about back where we were coming from is maybe that at the beginning and you also have this in the data now, and it's going to be repeated in every systematic review again and again, is maybe that we place too much material. Because you know this from harvesting connective tissue. You're working at the palate and you think you're harvesting a huge piece. And then you place it in the recipient side, and the first thought is, oh, it could have been more. As soon as you're treating sites with more than one missing tooth, you're getting at a certain border of what you can harvest for this. And maybe because there was unlimited availability, which is a strength of the substitute, maybe people placed too much of it and stuffed it into the side. And maybe also because it has this this property of being compressed then. So you have the feeling to really have to feel it. Nowadays, I use much less material, and I try to, compare to the same intervention with CTG, I try to get much, much more release.
I get it. There is actually a question which fits perfectly into that from Lucrecia. Hi, Lucrecia. She asks, how important is the length? I mean, you're now showing a dental spot of 2 teeth. Do we have the same thing like we have for bone defects, like you say a bone defect in the curvature? Or how important is that for you in your thinking?
That's a very good question. So from the CTG, we actually rather learned to place them also buccally deep into the vestibulum, to have rather a large graft, to have a larger surface where you get nutrition again. It has to be well stabilized there. Huh? If the flap moves, you will not get it. But with good stability, this is helpful, especially when you have a situation like immediate implant placement, where you might leave a little bit of the material exposed. So my personal rule is then to have 80% covered inside the flap to get the nutrition. Now with the substitute, I also do this differently. I try, as I need more release of the flap, I don't want to place more than I need. So I really place it only in the aesthetic area. I place it basically on the crest and on the buccal aspect. I'm not going on the buccal side into the vestibulum.
Got it. Okay.
Okay, so this is basically the summary. So range of indications today, maybe a little bit smaller. And then the susceptibility to compression, you need a lot of release. And for me personally, the ideal situations are sites with matured tissues where you want to create more volume for aesthetic purposes. And this is typically the area from 1.5 to 2.5. And the evidence for this is low, or it's even just an expert opinion.
I mean, Stefan, if we talk about this, then I would have just a very small comment. Why are you not using a dermal matrix? I mean, it pretty much has the same property than skin. What holds you back from using a dermal matrix?
I tried. We never did research with it.
I know, yeah.
You have you really don't have the problem with the compression. This is right. I am not so sure about the integration of it.
Yeah. And the early healing?
And early healing is maybe even more delicate. But I have to say the product we have been watching now is also delicate.
Yeah. Okay. So I think both of them have their advantages and disadvantages. I mean, I also work with both of them. I can totally underline that. The one is quite less sensitive, like the collagen matrix, but the dermal matrix gives you more volume, but is a little bit more critical in the early healing phase.
Yes, and then maybe if we go back to your case, the reason why I mainly use autogenous tissue in immediate implant cases is because you leave a part of it exposed.
Yeah. I get
There
it.
was a study from Ignacio Sanz Martin. They used a different product than the one you have seen before here. We have used that one in the rat study as well. And there they also didn't have that favorable results in conjunction with immediate implant placement.
Okay, perfect. Get it.
Now, it depends again on the patient's expectation. If this is an 85-year-old man with a low lip line, you maybe did the best thing you can do. You preserved some of the volume. You're going to have healthy tissues around the implant later on. And if you really want to get the absolute maximum out of it, I would rather go for autogenous tissue.
Get it.
Okay. So this was my presentation. I would like to thank the clinic in Zurich, also the team in the office. And on the right side, you see Ryoshi Sasaki. He's doing most of the prosthetic works. He's my dental technician.
Stefan, that was amazing. That was a real masterclass. I learned a lot, and we have questions here. We have a lot of people logging. So thank you very much for this great presentation, and for really also putting the finger on the most critical things of soft tissue management. I think you totally nailed it down, the areas which are important. And with this, thank you very much, and I'm happy to hand over some questions to you. There's another question from Ahmed. Maybe you addressed it, but maybe let's make it even more clear. When is the cut-off line for you to use autologous graft compared to a soft tissue graft? And I think you clearly said now, if you're using a soft tissue graft, you tend more to use these volume stable matrices.
Yes. So I think what we maybe didn't focus in this comparison directly is, again, the factor of a patient. So just recently, I had a case with 2 central incisors, and I would have loved to use autogenous tissue there to get as much of a central papilla as possible. Now, she's a dental hygienist. She said, if there's any option to not go to the palate, I will take it, no matter the outcome. And so we decided to use a substitute. So I think I can't give you a recipe for this. It's really a decision you have to make with your patient. But nevertheless, I think it's important to know a little bit what you can expect if you use either the one or the other. Because this is something the patient doesn't know. You have to tell him so that he can maybe understand and be part of the decision then.
Get it. Stefan, there's another question which concerns a little bit a classical punch grafting technique. I mean,
yes.
What about this one? We haven't heard about this one. It was quite famous from your department some years ago, I would say. Is that old-fashioned? Did we leave that, or are we still using these punch techniques?
So for me, it's old-fashioned.
I hope your boss doesn't hear that.
I have 2 cases. They are still in the recall. And if you unscrew the implant crown, you can basically see the punch lying in the submucosal tissue still there. And every 2 or 3 years, I have to cut away a little bit of tissue in the mucosal margin because it's growing out there and it's not looking nice. It's a rigid and a good tissue. It also tends to proliferate. I think the healing is rather critical. What I do quite often is I might also not be the one who does ridge preservation most often inside our department. But what I like to do is, if I have really complex cases, is I do the ridge preservation not with a punch graft, but with a connective tissue graft. Basically meaning it's the same as you did with your immediate implant. It's exactly the same procedure like we do it when we do immediate implant placement. with a split flap on the buccal side, just that you don't place the implant at the beginning. And I think for the biology, what is happening around is exactly the same.
Maybe it's even better, right? If you put it into the buccal like envelope.
Yes, you get much more nutrition for your graft from there.
Stefan, great. There's one more question. Actually, this question comes from my side. You always showed like soft tissue management as more or less a separate surgery. I mean, you already sort of were a little bit critical with a lot of surgical intervention and so on. Would there be a chance to sort of like integrate a soft tissue management into your implant procedure? Like meaning we have enough bone to place my implant and then I add connective tissue graft or add the volume stable matrix. Is that something you consider?
Yes. So first of all, we shortly mentioned at the beginning with time points. So I'm also placing quite a number of immediate implants where I combine it. And many of my immediate implants also get a connective tissue graft. And then you have the option, as you just mentioned, you have enough bone. Then it's always nice if you plan for it. So guided surgery, if you first raise a flap and then you see, okay, I could go for soft tissue directly, then you already have a mucoperiosteal flap. Ideal would be a surgery where you go guided and where you might start with a split flap procedure from the beginning. What I don't like to do that much is the combination with the abutment connection. Because I like to place my grafts and also the substitute around this buccal contour, so also a little bit on the crest, even though I know we cannot gain vertically like this, but I don't like to combine it.
I got it. I see it absolutely the same. And also like a closed healing is obviously more predictable. One last question, Stefan, then I leave you for your evening for a glass of wine. Arwa has a question, but I think we already answered that, but let's clarify it a little bit more. She asks us, or you, is it really true that the tuberosity tends to grow over time and we need to plasty it every now and then? Have you seen that for tuberosity also, or do we only see that for these deepithelialized grafts?
Oh, sorry, my voice. I cannot really answer it because I didn't do enough tuberosity grafts. I'm considering it from time to time. However, I find it hard to have a good side where I can harvest enough tissue. I might only apply to 10% of my patients. And also in terms of the shape and how you use that, for augmentations around implants, I think you rather need larger grafts. Might be different if we would be talking about recession coverages, localized ones. But therefore, I'm not using that many tuberosity grafts. In terms of the pain and the morbidity overall, it's actually for sure the better side than the lateral palate. And also the quality of the tissue. But in terms of proliferation, I'm not sure.
But also sometimes, if I may say that, a little more risky tissue because it's very dense and fibrous. So maybe just from my side, this advice, I would be a little critical because it needs a lot of good healing. It needs a thick flap because it's very dense, right? Is that what you also see?
Yes, definitely. Yeah. Yes, it's very dense. From a conceptual point, we know that if you have a good wound stability, after 5 days, you expect to have anastomosis between the vessels inside your graft with the surrounding tissues. There's less vessels. This is maybe, Stefan, what you mean. There might be more difficulties for integration.
True. Stefan, that was amazing. The people applaud you. I loved your presentation. I loved your points, exactly clinical relevant points. I'm more than happy that we shared this 45 minutes together. And you know what? 45 minutes are already up, so our time is up. I leave you for your evening. I say good night to everyone. Please again switch on next month again for the Just Ask. If you're interested in further education, look at the EAO homepage. There are a lot of curriculums, a lot of educational things which we are offering. And of course, look at the other Just Asks, also nice Just Asks we did. With this, I would like to say thank you to Dr. Stefan Bienz, also on behalf of the EAO and EAO board. And Stefan, have a great rest of the year. We'll see each other definitely next year. And hello and good night to everyone all around the world. Ciao, ciao, good night.
Thank you very much. Have a good night.